بسم الله الرحمن الرحيم. موضوعنا يتعلق بغير فرع من فروع طب الأسنان وفرع البروستاتيك. موضوعنا اليوم هو preprosthetic surgery. This figure shows the growth of the jaw, upper or lower jaw, and this figure shows the lower jaw, how it forms. That is when there are complete dentition, there are the lower teeth and the body of the mandible and the ribs of the mandible. The body have the upper part of the alveolar process and lower part the base of the body of the mandible. After extraction of all teeth, there are no function for alveolar process. So according to the functional theory, that lead to a resorption this alveolar process. So in figure D, the alveolar process is become smaller, and in figure E, the only remain the base of the mandible. So you must reconstruct the denture for the lower jaw and the upper jaw. There are a great variation extent in bone resorption among individuals. In many patients, this resorption process tends to stabilize after a period, where in other continuation of the process eventually result in total loss of alveolar bone and underlying base bone. The resorption accelerated by wearing a denture and tend to affect the mandible and more severely than maxilla because of the decreased surface area and less favorable distribution of occlusal force. فلهذا, when doing any denture, complete denture, you must be correct vertical dimension and correct occlusion to be maintained the bone of the upper and lower jaw. This figure shows how the jaw resorption from the first one in upper in A and in B, the lower in A, the maxilla, the one have complete dentition. After extraction the tooth, there are resorption of the alveolar process in figure 3, 4, 5, and only the palate stay in figure 6. In figure B, the when there are dentition, after extraction of the tooth, there are resorption of alveolar process until in figure 6 the base of the mandible is present. The objective of preprosthetic surgery is to create a proper supporting structure for subsequent placement of prosthetic appliance. أهم شيء في صناعة الدنشر هو good mucosa, good bony support to be stable and a good retention of the denture. The base denture support has the following characteristic. هذه هي characteristic feature of the denture base. First, no evidence of intraoral or extraoral pathological conditions. Second, proper inter-arch-jaw relationship in the anterior-posterior, transverse, and vertical dimension. Third, the alveolar process that are as large as possible and of ideal shape of the alveolar process is broad U-shaped ridge with the vertical component as parallel as possible. And other, no bony or soft tissue protuberance or undercut. Adequate palatal vault, proper posterior tuberosity notching, adequate attached keratinized mucosa in primary denture bearing area, adequate vestibular depth for prosthetic extension, added strength where mandibular fracture may occur, protection of neurovascular bundle, and finally, adequate bony support and attached soft tissue coverage to facilitate implant placement when necessary when considering more advanced preprosthetic surgical treatment. The principles of patient evaluation and treatment plan. You must take a case sheet for any patient come to your clinic. The case sheet contains first the chief complaint. Aesthetic and functional goal of patient must be assessed carefully. حقيقة لعمل الدنشر not have good mastication or aesthetically, mainly for upper and lower lip and the cheek. And then medical health. The general health is important when considering more advanced surgery because many of the approaches require general anesthesia, donor site surgery to harvest autogenous graft material, and multiple surgical procedures. Specific attention should also be given to possible systemic diseases that may be responsible for the severe degree of resorption. حقيقة إنه أكثر اللي راجعون for complete denture هم old age، فلهذا must concentrated on medical health. And when one of the items that present in the case sheet is laboratory tests, such as serum level of calcium, phosphate, parathyroid hormone, and alkaline phosphatase may be useful in pinpointing potential metabolic problems that may be affect for resorption. في أكثر الأحيان البيشنت in old age هم عندهم osteoporosis، فلهذا bone راح يكون very fragile. So you must, when taking an impression, you must careful after after you do the laboratory investigation, and you can see take an X-ray for if there are present osteoporosis or not. And the psychological factor and ability of patient are important determinants of their ability to function adequately with complete or partial denture. The psychology of the patient is important for old age when doing any denture. We have intraoral and extraoral examination should include an assessment of the exciting-occlusion relationship, the amount and contour of remaining bone, the quality of overlying soft tissue, the vestibular depth, location of muscle attachment, the jaw relationship, the presence of soft tissue or bony pathological condition. You must examine it before starting any. The examination of supporting bone should include visual inspection for assessment abnormalities of the remaining bone, palpation of all area of maxilla and mandible, including the primary denture-bearing area and vestibular area. Radiographic examination are important of initial diagnosis and treatment plan. The radiographic that include panoramic technique provide an excellent overview assessment of underlying bone structure and pathological condition as impacted teeth or portion of many roots, the bony pattern of elder bone, and pneumonization of maxillary sinus. In a panoramic view, you can see all the maxilla and the floor of the nose and the floor of the maxillary sinus, and beside it all the mandible from the body to the condylar area. Other view have cephalometric radiography may also be helpful in evaluating the anterior mandibular ridge and the ridge relationship in vertical and anterior posterior dimension. The more investigation that include CT that computerized tomography scans are particularly helpful in evaluating the cross-sectional anatomy of maxilla, including ridge from the sinus anatomy and location of inferior alveolar nerve if needed for computerized tomography. And last thing, evaluation of the modules. For evaluation of denture-bearing area of maxilla include the bony ridge form, the no bony undercut or gross bony protuberance that block the path of denture insertion in area of buccal vestibule or palatal vault, palatal tori that require modification if there are excessive bony formation in the palate, as palatal tori must be removed and relieved before doing any denture, mainly complete denture. Adequate posterior tuberosity notching must exist for posterior denture stability and peripheral seal. The mandibular ridge that include the remaining mandibular ridge should be evaluated visually for overall ridge form and contour, gross ridge irregularities, tori, and buccal exostosis. Any abnormality in the ridge must be relieved if there are severe undercut, if there are irregularity, if there are knife edge, if there are tori in the lingual side of the mandible, if there are exostosis in buccal and lingual bone. The muscular and mucosal attachment near the crest of ridge, particularly in the posterior mandible, where a depression palpated between the external oblique ridge and the mylohyoid ridge. If there are vestibule is shallow due to its resorption of other process, and there are a huge amount of external oblique ridge and mylohyoid ridge, so you must relieve this two ridge and then do a denture for good support and stability. The location of mental foramen in relation to the superior aspect of the mandible. If the mental foramen at the top of the ridge, so you must relieve the nerve and then do a denture. For evaluation of supporting soft tissue, a bony part you must evaluate. This assessment of quality of tissue of primary denture bearing area overlying the alveolar ridge as the amount of keratinized tissue firmly attached to underlying bone. So the mucosa must be firmly attached, not any flabby, not any movable mucosa. Palpitation discloses hypermobile fiber tissue inadequate for stable denture base. So, by moving the mucosa, if there are any movement, so-called it's hypermobile fiber tissue. This is not give a good impression for the upper and lower jaw. So we must remove the mobile fibers tissue and then do a denture. The vestibular areas should be free of inflamed, scarred, or ulcerated area caused by denture pressure or hyperplastic tissue resulting from the ill-fitting denture. Yeah, the vestibule must be healthy, pink in color, no any mobility, no any ulceration, no any discoloration, change in white or red in color, or any mass or hyperplastic tissue. You must remove it if there are present. Assessment of vestibular depth should include manual manipulation of the adjacent muscle attachment as a frenum at the crest of the ridge, the loss of peripheral seal of denture bearing speech and mastication. We must examine the vestibule by your finger, and you can see its depth. It is enough depth for doing a flange of the denture, so it is very enough. But if there are shallow vestibule, there are not enough flange, so we must create a vestibule by a surgery. The lingual aspect of mandible should be inspected to determine the level of attachment of mylohyoid muscle in relation to the rest of the mandibular ridge and the attachment of genioglossus muscle in the anterior mandible. حقيقة حركة الtongue and حركة the floor of mouth its effect on the stability and retention of lower jaw. So, by its attachment of mylohyoid muscle to mylohyoid ridge and its attachment anterior genal tubercle genioglossus muscle that have not good stability in the lower jaw. The lingual vestibule depth should be evaluated with the tongue in several positions. The movement of the tongue is effect on the stability of lower jaw. So, by a protrusion, retrusion, lateral movement of the tongue evaluated when doing any denture for by recontouring of the ridge, we do that smoothing of the alveolar process and then do a denture. Simple alveoloplasty. The second technique that used for the recontouring of the ridge is the simple alveoloplasty. Alveoloplasty by doing a horizontal incision above the ridge of the upper or lower jaw and then remove the sharp bone, the knife edge bone, mainly in the socket area, and smooth it by the bone file or by burrs, surgical burr, and then do suture by interrupted suture or matrix suture. So after 7 days, we can remove this and you can do your denture. This figure shows the surgical technique of simple alveoloplasty is for the patient. We can see in figure A how it's many extraction for the patient and mainly anterior teeth that have lead to irregularity of the alveolar process that do incision on the crest and then remove by bone cutter or bone nibbler to the sharp bony subbone and smooth it by bone file or by round bears, surgical bears. So and suture it and after 7 days do the denture. For lower jaw, if there are knife edge alveolar process above the base of the socket, so not give a U-shape alveolar ridge, so it need to rounding this knife edge by do an incision as horizontal incision only, and by bone nibbler we can remove the sharp edge and then smoothing and rounding the bony ridge mainly anteriorly and the resuture, and after 7 days we can do an impression. The other procedure for the maxillary teeth is interseptal alveoloplasty. If there are a severe undercut in the buccal mucosa and the buccal side of the maxilla, so we can do a simple interseptal alveoloplasty. After serial of extraction for the posterior teeth, we have do an incision on the alveolar ridge and then cut the interseptal bony between the tooth and between the roots, and then press from a buccal side, so reduce the size of alveolar bone and eliminate the socket. The advantage of simple interseptal alveoloplasty is the labial prominence can be reduced without reduce the height of ridge. The posterior periosteal attachment can be maintained. The muscle attachment can be left undisturbed. This technique less resorption. But there are main disadvantage is the decrease in ridge thickness. The anterior-posteriorly become less thick than upper to lower size of the ridge. The other technique for maxillary jaw or upper jaw maxillary kyphosity reduction. We have two types of excessive of increase in the size of maxillary kyphosity, either bony as a hard tissue or soft tissue for mucosa. So if it is hard tissue, we do elliptical incision on the tuberosity and remove it by a bone nibbler or bone cutter, and smooth it by bone file or by surgical bear, round surgical bear, and then do suture by interrupted suture or matrix suture, and until 7 days. If remove the suture, you can do a complete denture or partial denture after eliminate the undercut of the bone. Excessive overlapping soft tissue resulting from the bone removal is exceeded in elliptical fashion. After reduction the size of the bone, there are excess in the mucosa that occur. So we excise it and remodel it and then suture. Attention-free closure over this area is important, particularly if the floor of the sinus has been perforated. You must do a closure by suture it without any tension. So if there are any tension, lead to break of the suture due to the failure of operation. Suture should remain in place for 7 days, and initial impression can be made for a week or after surgery. We can do an impression after 1 month of doing your removing of the suture. In the event of a gross sinus perforation, the use of post-operative antibiotic and sinus decongestant given for 7 to 10 days. If there are perforation to the maxillary sinus, you must give him a decongestant spray with antibiotic and analgesic for prevent any infection of maxillary sinus. Amoxicillin is usually antibiotic for choice and less contraindication by allergy. The best drug of choice is amoxicillin or augmentin that have amoxicillin and clavinic acid that giving for the patient. If patient have allergy, we can give erythromycin. We give, if there are any perforation for maxillary sinus, we give the sinus decongestant such as pseudoephedrine with or without an antihistamine. The patient is informed of cautious agent creating excessive sinus pressure such as nose blowing or sucking for 10 to 14 days. So, if there are any perforation that within the nasal cavity, so we must not have any blow from the nose or suck from the oral cavity to prevent any destruction and communication that have lead to fistula between oronasal fistula. Other technique we call exostosis and excessive undercut. If there are in the anterior part of the maxilla, if there are excessive undercut that have not taken a good impression, mainly if there are complete denture, you must do an incision on the ridge of the anterior teeth and then can cut the labial bone by round wear, surgical round wear, and then smooth it by a bone file, and then you can return the mucosa and after debride it and remove the excessive part of tissue and suture it and then do an denture after 7 days of removal of suture. Extremely large area of bony exostosis generally require removal. Small undercut area are often best treated by being filled with bony graft. If there are severe undercut, and if remove it, this undercut lead to very thin alveolar ridge, so we do another technique by bony graft. We do cancellous bony graft and fill the undercut area, and then do a simple incision in the labial side of the upper mucosa or in the lower mucosa, and then fill it by bony graft and one type of bony graft that have and fill this undercut and then do an impression, and this is enough for this technique. This technique can use is by do a channel, by do incision, vertical incision in the labial at the side of labial frenum, and do a channeling beneath the mucosa and above the periosteum, and put either cancellous bone for autografting or calcium hydroxyapatite and mix it with the blood and to put it in channel and then do a suture, and for 1 month can do a denture. If the exostosis in the palatal side, so lateral palatal exostosis, if any bony prominence in the palatal side, we can do an incision over exostosis and remove it by bone cutter or bone nibbler, and by a bone file we have smoothing the bony part and then suture it by interrupted suture, and after 7 days can remove the suture, and after 1 month can do its denture. Other problem for maxilla is maxillary tori. As you see in this figure, we have huge bony exostosis in the palate. It is either smooth, large, small, or irregular tori that have small or large that extend from the palatal side of central and lateral incisor to the palatal side of the The maxillary tori consists of bony exostosis formation in the area of the palate. Tori are found in 20% of the female, approximately twice the prevalence in male. The shape of tori ranging from single smooth elevation to multi-loculated pseudo-nucleated bony mass. The tori that with full denture that have lead to interfere with the speech become ulcerated from frequent trauma to the palate. Tori in full or partial denture construction may interfere with the proper design function of prosthesis. The large tori should be removed before denture construction. The technique that remove the tori by two incision, Y-shaped incision from anterior side in premaxillary area and posterior side for the soft palate, and connect it by horizontal incision that go and reflect the flap, and can remove it either by pair and can cut it a small piece, or by chisel, and then use a bone file to smooth the bony structure and return the bilateral suture for 7 days. This figure shows a multi-lobulated maxillary tori. By chisel can remove it and can smooth it by bone file and suture it. We have certain local care that have include vigorous irrigation. You must, when use the surgical bears, you must irrigate because this high speed lead to necrotic of bone. Good oral hygiene. You must have good oral hygiene that give any patient a mouthwash, and then if the oral hygiene become good, then doing a denture. Support with soft tissue condition. If the soft tissue is normal, no over excess of the mucosa, no any undercut, no any interference with the muscle of mastication, or interference with other irregularity of the soft tissue. You must good adequate treatment plan for the patient before doing any denture. The major complication after removal of the maxillary tori: first, post-operative hematoma formation, if not give support by for the mucosa by putting periodontal pack, or put acrylic plate over the area that remove the tori to have not any bleeding and formation of hematoma beneath, so lead to an removal of the suture and then lead failure of operation. The second one, the fracture of the vault of the palate. If you use hammer and chisel, be careful to not fracture to the soft to the hard palate and go to the hard palate to be not fracture and lead to oral nasal fistula. This perforation of floor of the nose. This lead to necrosis of the flap that do incision in the flap by strong attach to the bony support, and there are excessive force to suture, so lead to have necrosis of flap. Now for the mandible, we have mylohyoid ridge. So how mylohyoid ridge reduction? In case of severe resorption, augmentation of posterior aspect of the mandible rather than removal of mylohyoid ridge. If there are excess elevation of mylohyoid ridge and the very shallow alveolar bone, you must remove it by cutting this part of bone, or by putting bone graft to increase the size of the alveolar process. This technique for increase the alveolar mylohyoid ridge by can remove the mylohyoid muscle and reattach in the lower surface of the base of the mandible to be increase the vestibule after removal attachment of mylohyoid ridge. You can do by one file or one cutter, and then by then use a bone file to smoothing the bone and re-suture this side of the lingual side. Other problem for the mandible is the mandibular tori is the same as in maxilla, but its location in the posterior distal and lingual to the second and first premolar, and can remove it as either smooth or lobulated. There are a single or multiple bony tori. We can remove it like maxilla. We remove the elliptical shape of the above the ridge of the mandible, and by round surgical bone, we can remove it and remove this side, smoothing by the bone file, and then suture it. After 7 days, you can remove this by bone chisel and hammer to remove it, but it is not beneficial for the patient. We can remove this and by smoothing the mylohyoid ridge and then resuture of the. ذكرنا سابقا أنه tuberosity can enlargement of tuberosity either hard tissue as bony structure or soft tissue as mucosa. Now we discuss the maxillary tuberosity direction for the causes of soft tissue. The primary objective is to provide adequate interarch space for proper denture construction in the posterior area, a firm mucosal base of consistent thickness over the alveolar ridge, denture-bearing area. The amount of soft tissue available for reduction can often be determined by the orthopanoramic radiography or by a sharp probe. We use a periodontal probe to measure if there is soft tissue enlargement or bony enlargement. If there are soft tissue enlargement, the procedure technique after giving anesthesia, an elliptical incision is made down to bone and the ellipse of soft tissue excised. The scalp creates an oblique cut as seen in a cross section. The underlying submucous filtered to reduce the bulk of tuberosity. The wound edges are opposed and sutured, and then after 7 days, you can remove the suture. This figure shows the technique that used for reduction the soft tissue procedure maxillary tuberosity. This figures a clinical figure for reducing the soft tissue enlargement of tuberosity. The other soft tissue abnormality is the lateral palatal soft tissue excesses. Soft tissue excesses may interfere with the construction of the denture. Soft tissue hypertrophy often narrow the palatal vault and create slight undercut which interfere with the denture construction and insertion. When our increased enlargement of the size of the soft tissue on the palatal side, mainly in the maxillary tuberosity, that lead to severe undercut, and the soft tissue can compress during taking an impression. So when complete the denture and the patient insert in the mouth, there are difficulty due to the presence of undercut. So by elliptical shape incision, we can remove the soft tissue as in the previous maxillary tuberosity. Another problem that occurs for the soft tissue is unsupported hypermobile tissue. If there are excessive hypermobile tissue without inflammation on the alveolar ridge, is generally the result of resorption of underlying bone, ill-fitting denture, or both. If there are by palpitation of the mucosa, mainly in the anterior side of maxilla, and in the anterior side of mandible, there are mobile over the bony structure. This occurs either severe resorption of the bone in rapid period, so not have the mucosa is decreased in size within the bony structure, or ill-fit denture that over denture that have high pressure that lead rapid destruction to the bone with their increase the amount of the soft tissue. The hypermobile tissue in the crystal area of the mandible which frequently consists of small cord-like appearance band of tissue. This is a hypermobility that have done it by size at the narrow area of the hypermobile tissue and then do undermining to the mucosa labially and lingually and then do a suture of the incision. Other problem that occur to the soft tissue is inflammatory fibrous hyperplasia. A generalized hyperplastic enlargement of mucosa and fibrous tissue in the alveolar ridge and vestibular area due to ill-fitting denture. في حالة flange of the denture is very long, so that compress on the depth of vestibule, and this continuous irritation of this vestibule that lead to have formation hypertrophic or hyperplasia structure as inflammatory fibrous hyperplasia. In early stage of fibrous hyperplasia, non-surgical treatment is sufficient for reduction or elimination of this tissue, when the surgical treatment by excision of hyperplastic tissue. في حالة small fibrous hyperplasia فقط patient cannot not wear the denture فيرفع التخم من مكانه فهذا the simple hyperplasia can go and resolve. But if it is as large as in this figure, we can do incision to the hyperplagial tissue and suture it and then do recontour of the denture or new denture for the patient. This figure shows that how we can do the incision for the hyperplastic tissue, and then after, if there is a huge amount of hyperplastic tissue that have not enough space for suturing, so we leave it and put a periodontal pack on the ridge to be epithelialization over the bony structure. Other technique that used for removal of hyperplastic tissue by using a laser. So laser excision of large epithelios allow complete removal without excessive scarring or bleeding that occur. By using a diode laser as incision for the hyperplastic tissue, if there is very large, the laser technique that had lead to stop bleeding from capillaries and have a clear field, and then put a periodontal pack and secondary epithelialization that occur and return in normal as in this figure. The frenum, labial and buccal frenum in a maxilla and the mandible. The frenum is the bundle of the connective tissue that connect the lip to the or cheek to the mucosa of the labial mucosa and buccal mucosa. So, if the labial frenal attachment consists of thin band of fibrous tissue covered with the mucosa, extending from the lip and cheek to alveolar periosteum, and may reach to the crest of alveolar ridge, and even to incisal papillae area. The frenal attachment may complicate the construction of denture. The movement of soft tissue adjacent to the frenum may create a discomfort and ulceration and may interfere with the peripheral seal and dislodge the denture. The technique that used for removal of frenum as a frenectomy, first technique is simple excision. We do and do incision from the alveolar process by side of the frenum attachment and go to the depth of vestibule, and then from the labial mucosa that have a side of the frenum till the depth of the vestibule. After removal of the frenum by frenectomy, we do the first suture at the depth of vestibule and suture the labial mucosa and suture the gingival mucosa by interrupted suture. This figure shows how this technique and the first incision at the depth of vestibule to have create a correct and adequate depth for the flange of the denture. The step for this technique, first step, initial incision. We do make incision 15 centimeter blend an angle 45 degree to the underlying bone. Then excision of overlying tissue. Use incision tissue inside forceps to hold the flap edge that and hold the flabby mucosa flap by size it labial mucosa. Then soft tissue release and the wound edge, then a suture, and then excision of the frenum. Other technique use if there are a huge amount of the frenum that have not can easily removal by a simple frenectomy, we use zetaplasty technique. You put two side incision at the upper margin and lower margin of the frenum by as a Z-shape technique, and then incise it and suture it. This figure shows how it's put two incision at the labial frenum and the labial mucosa in one side and the depth of vestibule in the other side, and then can remove the frenum on both sides and incise it and do remove the suture after 7 days. This figure is clinical presentation of how can removal the frenum by zetaplasty. The other technique, if there are very band frenum that cannot remove it by simple alveoloplasty or simple the zetaplasty, we can remove it by other technique, call it localized vestibuloblasty with secondary epithelialization. We can remove the frenum by incise it from gingival side and from labial side and leave and wide area is the labial side and in the gingival side. We suture in the labial side with the end of the mucosa with the surrounded mucosa that then within the gingival side, and put periodontal pack for 7 days, and then secondary epithelialization that have formed and return normal mucosa, and then can do it a good flange for anterior side. Other technique by using a laser. So the laser assisted frenectomy, you can do a normal frenectomy, not use a normal scalp, but use a laser. But this is a good technique for large frenum that have reduced the bleeding problem, the clear field, and healing is become very easy. In the mandible, we have the other problem is the lingual frenectomy. The lingual frenum is an abnormal frenum attached usually consists of mucosa, dense fiber connective tissue, and superior fiber of the genioglossus muscle. This attachment binds the tip of the tongue to the posterior surface of the mandible alveolar ridge, which affects speech and interferes with denture stability, because each tongue dislodge this by movement of the tongue. So difficulty in eating and difficulty in speech when were a danger. The frenectomy of this lingual frenum by put a 0O suture in the tip of the tongue and incise it from the ventral surface of the tongue, and by soft tissue forceps can attach to the frenal and remove it from the floor of mouth, and put the first suture at the base of the tongue and the ventral surface within the floor of mouth, and then continue suturing of the mucosa within the ventral surface and the mucosa of the floor of mouth. Now, after finishing the soft tissue problem, we go to other categories. There are immediate denture. This denture can reconstruct and give and take an impression before extraction of the teeth. After finishing doing the denture, we extract the teeth and insert immediately the patient in the patient mouth, so we can do it and the patient can go out with a denture without have any missing teeth for the outer person. The advantage of immediate denture: the insertion of denture after extraction offers immediately psychological and aesthetic benefit to patient. The immediate insertion of denture after surgery also functions to splint the surgical site, which result in reduction of post-operative bleeding, reduction in edema, improved tissue adaptation to alveolar ridge. The vertical dimension can be most easily reproduced. بهذا نحافظ على amount of alveolar process in larger amount than after 2 months that lead to have a severe resorption of the ridge. The disadvantage of immediate denture that include the construction of new denture after initial healing. نحتاج إلى أن نسوي new denture after a period from 6 months to 1 year. هذه لأنه راح يصير resorption الرج، راح يصير unstable denture، لهذا يجب أن نعيد a new one. The second disadvantage, the need for frequent alteration of denture post-operatively. هو حقيقة إنه نعيد نسوي relining for the base of the denture after a period and repeat it for many times. The anterior and posterior teeth can be extracted and denture inserted on stage with extraction of upper posterior and lower before anterior extraction. حقيقة بداية نبدأ extraction لل upper posterior and extraction lower posterior. After finishing that, we have do a denture and extract the anterior teeth and insert the denture. This allows for initial healing of posterior area and facilitate improved adaptation of denture over the alveolus and tuberosity in maxilla. This figure shows the cast how do by taking an impression by alginate, and after pour the impression and do a cast. Then by cast we can remove the teeth by hand piece, and they do rounding to the teeth and do a split, and then do a denture, and after patient come to clinic, extract the teeth and insert the denture. This figure shows the clinical of this technique.